It's my great pleasure to introduce Salim Yusuf. His CV is longer than everything I've ever published, so I'll try to just give you the abridged version. Most of you will know Salim. He was involved in initiating concepts of large, simple trials and meta-analysis, which led to the modern-day revolution in the evaluation of treatments in cardiovascular medicine. He's led over 50 major trials. Some of them have changed practice. Over the last decade, he's been involved extensively in research in developing countries. He's published over 750 articles, and his collaboration involves 80 countries around the world, inhabited in all of the inhabited continents. He's received numerous international awards, including the Prix Galien Canada in 2001, the Gold Medal of the ESC, the Clinical Research Prize of the American Heart Association, and in 2011 he was the second highest cited scientist in the field of medicine, and his institute is the seventh highest ranked institute in the world, the second highest in Canada in 2011, and he's the president-elect of the World Heart Foundation since January 2013.
Thank you, Andy. Well, thank you for asking me back after my rather not so gentle talk last time. I wondered whether Holger would ever ask me back to a meeting, but that's and congratulations, Dave. As usual, Dave keeps on stimulating all of us. Now, I recall a conversation in 1977, about a year after I went to Oxford, and discovered this mole called Richard Peto. And he told me, you know, just don't waste your time trying to do things other than a randomized trials. A lot of smart people have been trying to do this for 50 years to look at alternative methods, and they've never got it right. So just don't waste your career. It's too precious to lose. I remember that when I saw this term. Now, is it time to retire the randomized trial? Dave argues no. I'll say, whatever you argue, there are people out to kill the randomized trial. And it's actually happening right now in parts of the world. And I'll go into that it's being murdered or assassinated, and in fact, making it impossible to do them. So let's go to the, it's important to look back to know about looking forward. Before 1960s, RCTs were uncommon. Large benefits were undetected, unclear, or not reliably demonstrated. More importantly, large harms of what we were doing were missed. For instance, oxygen in newborns, at least in terms of the eye, chloramphenicol for childhood sepsis. And if you read Silverman's classic book, you'll see dozens and dozens of examples where well-intentioned doctors are doing the wrong thing. Now, small randomized trials were sufficient to detect such large effects. In fact, Bob Temple and I were whispering, it really doesn't matter what method you use. If you've got a large effect, you're going to pick it up. You may get the effect size wrong, but that's not true all the time. We'll look at that in a minute. And randomization, we know, controls for biases, both small and large, and between those receiving, between the controlled and uncontrolled group, as you say. Now, post-1960s, actually, many important therapies existed, like aspirin, thrombolysis, but we were missing, we missed knowing what they did. And that was the time I got into medicine, and I remember meeting John Keynes at Oxford at that time. I mean, he played a great role in discovering the role of aspirin in unstable angina. And around that time, we at Oxford did a meta-analysis of the trials of thrombolysis. There were 24 trials on a total of 6,000 patients. 5 were statistically significant reductions in mortality. 11 were non-significant benefits. 8 were neutral or non-significant. And a meta-analysis indicated a 25% risk reduction in mortality, but it was not accepted. That was the time when meta-analysis was rare. This paper was rejected about 4 times before it was published. And in fact, I remember the accompanying editorials. I mean, the Desmond Julian, the editor, commissioned 4 editorials. And one of them talked about drowning and pooling and garbage in and garbage out, and the usual things that you've heard. And being a young chap, it left a big impression on me. I was pretty discouraged. But anyway, we did that. And I remember coming to NIH a few years later, and I remember there was a lynching mob organized in the clinical trials branch on me by Bill Friedewald. How dare you do meta-analysis? Because the meta-analysis of aspirin trials gave the results that was opposite to AMIS. And AMIS had to be right because it was done at the NIH. You all know what NIH stands for, not invented here. So now I worked at NIH, but Susan, it's true. When you work in and you work out, there is a certain, but the key point here was meta-analysis, even in institutions that were reputable, understood methodology, was in disrepute. And this is, on one side, is the meta-analysis showing a 25% risk reduction. Thankfully, we did the ISIS-2 trials that showed that compared to placebo, streptokinase reduced mortality by about a quarter, aspirin by 20%. And the reason we studied aspirin was not because there was any basic science or biology data or even pilot data. It was because a meta-analysis of long-term trials that Richard Peter did showed a benefit. So he said maybe it will work earlier. And I think, John, you are part of the ISIS-2 as well. And the remarkable thing was the two together reduced mortality by 50%. This is the single biggest step forward in the therapy of acute myocardial infarction, one of the commonest and deadliest conditions. Now, at that time, Richard and I wrote an article in Stats Medicine, and at that time I thought meta-analysis was king. So we published this, and we looked at the estimated risk reductions from meta-analysis of a bunch of medications and interventions. And just yesterday, I updated what the trials have shown since then. Now, luckily for thrombolysis, one of the widely used meta-analysis, the large trial confirmed it, and that's also true for beta blockers. The meta-analysis and the large trials confirmed it. But most of the other things, they didn't. And if you look at GIK, nitrates, hyaluronidase, or magnesium, look at this, 50% risk reduction, about 6 zeros on the p-values. It wasn't confirmed by the further trial. And I must say, I was the senior author of this magnesium paper, and we wrote an editorial saying a simple, cheap, very effective intervention. We believed our meta-analysis. But looking back, the meta-analyses that were non-reproducible were based on a few hundreds or few thousand individuals and no more than a few hundred events. And for instance, the magnesium meta-analysis just had 200 events. And so, and the GIK meta-analysis again had about 150 events. So there were two essential principles we learned over time. The first thing is most of our experiments were still struggling to get internally valid results. So we've talked about minimizing bias and all that kind of thing. And this is an area that we in clinical trials have paid a great deal of emphasis, minimizing biases. And we've gone through a number of procedures, of which the most important is randomization, and the second most important is unbiased, but not necessarily precise ascertainment of outcomes. Now, blinding has been used, and you can see the value in trials where your outcome is subjective, but I can't see the value in trials where the outcome is hard, and hard is way beyond mortality. You can have good definitions of heart attacks and strokes, etc. Or there's the alternative: you do an open trial like surgery versus no surgery, but you do a blinded evaluation of the outcome. In a sense, that's what the TB trials, the first pulmonary TB trial was, or the large polio trial. The large polio trial is interesting. They randomized 400,000 children, and they did not actively search for events. They waited for children to be hospitalized with polio, then they matched the hospitalization for polio to the original randomization. So they could have missed, minor cases of polios, but that was unbiased. Now, Janet Spogue, who's here, did a comparison of adjudication of 100,000 people in 10 of our large trials, and it showed that the results of central adjudication on death, heart attack, stroke, was the same in blinded and unblinded trials, and the results were the same whether or not used central adjudication. Now, this is something that's forgotten, and we have this mantra, blinded, centrally adjudicated results. And this is something that we need to rethink, maybe a way of getting rid of some of the complexities. The other thing that is less often understood is the need for not just trials of 1,000 or 2,000 patients, but trials of 1,000 or 2,000 events. This is the key thing. And unbiased meta-analysis of moderate and large trials, and the reason is meta-analysis is an observational methodology. It's not a prospective methodology most of the time. You know what's out there. If you pull certain trials and combine it in certain ways, you know what results you're going to get. So you can have your exclusion and inclusion criteria of trials almost data dependent. You know what event there was an effect on even before you did a formal search and all that. So the only kinds of meta-analysis I tend to believe now are those that are based on large trials, and we exclude in most of the meta-analyses we do trials of less than 1,000 people or something like that, so that there's no publication bias. So what we really need is meta-analysis of large trials, not small trials, because small trials are potentially biased, and how you do the meta-analysis is biased. Now, one of the things about meta-analysis is it was something that every Tom, Dick, and Harry could do once you got these programs. And there were many good things about the Cochrane collaboration, but there were many bad papers that have come out of that too. Sorry, Andy. And, once you start to meta-analyze without thought, it becomes an industry. And that again, isn't a careful way of doing science. Now, a few years back, Janice and I wrote a paper which started off with the sentence: the standards for a good meta-analysis should be no less than the standards for a reliable trial. I mean, we would all agree with that. And so every meta-analysis, like a good trial, needs a protocol. It needs to make a meta-analysis as prospective as possible. It needs to minimize all kinds of biases, what trials you select, how you ascertain your endpoints, but you also need to take into account power. And so most meta-analysis, their methodology is focused on avoiding biases, and that's good, but they spend very little time on the concept of minimizing random errors. And we used a term called optimum information size, the equivalent of sample size. So for a meta-analysis, before you go in, you calculate what your optimal information size is, and if you say it's 3,000 events to pick up a 10% risk reduction, and you only have 200 events, a priori, your meta-analysis is hopelessly underpowered. I think you need to start with that point. I know that concept has been turned into a different term called fragility index for trials, but the same thing's true of meta-analyses too. Now, there are problems with the current trials, and this is something that can be fixed. The answer is not to throw it out, but to fix the problems. We've been focusing a lot on internal validity, but we really need to also think about external applicability. Surprisingly, the answer is very simple. Let's do really large trials in lots and lots of patients, in lots and lots of centers, and collect and have very few exclusions and simple inclusion. And many years ago, a group of us wrote a series of papers called the uncertainty principle. You only have one inclusion criteria and one exclusion criteria in your trial, not your 20 of each. The inclusion criteria is the clinician thinks you have the condition of interest. You don't define it anything more. I, as a clinician, think this person has an acute MI. 99 times out of 100, you're more or less right. And then you say, in my opinion, there is no exclusion criteria and no contraindication or indication to use the drug. So you're uncertain whether to use the intervention. And that's called the uncertainty principle. And in a sense, that's what the ISIS trials used. But today, if you go to a regulator, an ethics committee, or even a peer-reviewed committee, they will throw your protocol out, saying you haven't defined these things. In fact, all those definitions are wasteful and limit the extrapolatability and applicability of a trial. Then we collect tons and tons and tons of data. voluminous forms. I remember when we designed the ISIS-1 trial, entry was 3 lines of data on the back of an envelope, and at the end of 30 days was one side of a page. The grant was turned down first time, second time by peer review in the UK, and one of the concerns was, well, you're only going to answer one question in the study. And our response was, but we will answer one question. You know, today people try to answer too many questions and they muck it up. We usually have complex and relatively unhelpful study procedures. Strict definitions of endpoints don't really make much of a difference. I've showed you the adjudication story. That doesn't really make much of a difference as long as that ascertainment is unbiased. Most studies that use core labs, it's a waste of money. You know, you might as well get your ascertainment for most things in a simple but unbiased way, blinded or unbiased. Or as I told you, the polio trials, the endpoints were whatever they could find in the hospital. Or the recent CHAP study where they looked at the ISIS database as where the endpoints were. I think those are sensible. There are complex, and this is the biggest concern today, complex and various bureaucracy, and the things that have burgeoned is this SAE reporting. Now, I don't know how many of you know this. An adverse event or a serious adverse event is anything that can happen to you if you're in a trial. So, if you have a heart attack and you have a bit of chest pain, well, that's an adverse event. If you have if you're sitting on a chair and you're in a trial of a vitamin, you accidentally spill coffee, that's an adverse event. And you've got to start to then fill out pages and pages of stuff. And I'll show you in a minute how wasteful this is. The other thing is on-site monitoring, which is by and large a useless procedure unless you do it as a quality improvement method. And then now, this is what's going to kill trials, and it's done it in one large country in the world for the moment. It's compensation for those suffering an adverse event or a serious adverse event, even those in the control group, and even those that are unrelated to the intervention, and even those that happen in the usual clinical course of an event. So, if you do a study with a heart attack, you're going to be sued by every patient. They're going to have arrhythmias, they're going to have something happen to them, and you're in trouble. So either you'll stop doing trials, or you'll only put healthy people into trials. Now, here is the example from Janice Polk's paper on adjudication, and you will see primary outcomes. This is about 10,000 events, and you will see adjudication versus no adjudication. It's the same result. CV, cause-specific death, myocardial infarction, stroke, the same result. And masked versus unmasked trials, pretty much the same. And, we saw that in the RELY trials where there was a masked component and an unmasked components, and you couldn't detect any biases. Now, we tend to misunderstand the impact of random errors versus systematic biases in terms of ensuring data quality. Random errors is just noise. And as long as that there is no reason to expect it differentially between your active and control group, it doesn't matter that you have to standardize everything. For instance, when you do trials of certain conditions, you want to standardize every little thing. Maybe you can standardize in a trial of blood pressure, just the blood pressure maybe, but the others let it happen. And even there, as long as your interpatient variability in response is larger than your measurement error, even there it doesn't matter. It's the ratio of those two that make a difference. The source verification of documents, which is standard in industry trials and monitoring, has grown. And I hate to tell you this, Bob, your auditors don't have no sense when they come to look at these. And since companies panic, if you get an audit report that is negative, they then dump on the investigators. And this is a part that is a huge industry. The cost of most trials of industry, about a third to half of it is the monitoring cost. So imagine if you were able to do 2 trials just as complicated as industry for every 1 trial. I mean, how much further the money would go. Key information documents, if you're really interested, can be sent centrally. For instance, in some of our studies, we say, send us all your ECGs. Not because we want to read the ECG. You want to see if all 10,000 ECGs in your trial are identical. Then you know it's the same patient. And we found a unique use of genetics in a study, where in one study, 54 people from the same center had the same sort of genotype. So there are some useful ways of dealing with this, but you can deal with this centrally. You can pick up fraud centrally. And one of the things is picking up fraud centrally is more efficient than sending people out on site visits. The site visits are useful in detecting sloppiness and poor record keeping, but they may just be random. It's not that I'm condoning sloppiness. The issue is how precise should you make everything be? And so, so one of the things that, again, Janice has worked on is the strategy of using central statistical monitoring to detect fraud. And there are several items in the method that we've developed, but you can develop your own method. You look at the frequency of binary data within a center, compare it with overall data and with other centers in the same country, mean values of a variable, digit preference, variance comparisons, distance comparisons, outcome probability, and repeated measures. The problem with all of this is you need a reasonable number of people within each center to do it. That's the only thing. But then if you turn it around, if you only got few people per center, even if it's fraudulent, it's going to have no impact on your data. Now, the other thing is when you look at the data in one of the studies that my good friend PJ had the misfortune of leading, or the fortune of leading, the Poystar, we had 9 centers we detected fraud. And when you look at the data without the fraudulent data, and I think these were about 800 people in the fraud, based on the fraud centers, and about 8,000 in the rest, you will see the hazard ratios are nearly identical, although the p-values are slightly off, which means the fraudulent data was just adding random noise. It wasn't adding bias. So yes, we have to condone fraud, but on the other hand, should we go into convulsions about it? Now, I'm going to spend in the last 2 or 3 minutes something about SAEs. First, I think this term should be dumped, because what you're saying is anything that happens to an individual is an AE or SAE. And it's a term that's widely misunderstood, especially by lay people, because they assume the moment you say it's a serious adverse event, it has to be related to the drug or your intervention and participation in the trial. So I think we need some other term for it. And events that are part of the clinical course are considered now AEs and SAEs by GCP, whatever regulations. We need, and it replaces reporting, and we have to replace reporting of individual AEs to looking at the data in groups by, say, a data monitoring committee. And I think in the FDA's recommendations, that one of the recent guideline documents, it says so, but most of the world haven't picked it up. Relatedness, by and large, is useless, because if it's something unexpected, there's no reason for you to think it's related. And say you're studying people with a heart attack, and you're going to get an excess of heart attacks. Well, how can you guess it was related? It's only by comparing the groups you could say that. Unexpected is generally hard to assess, except for those unusual cases, like liver failure, or agranulocytosis, or anaphylaxis, and those are easy to pick up. So we have to simplify this SAE part. As an example, in the RELY trial of 18,000 people that we run for 2 years, we had 6,200 SAEs, 123,000 adverse events. Imagine the paperwork this led to. And the only difference between active and control were bleeds. But we knew antithrombotic drugs increases bleeding. The work in this trial could have been reduced, by about 60% had we had a sensible approach to AEs and SAEs. Now, this is in 2004, for some reason, I wrote an editorial in the Canadian Medical Association Journal, like the JAMA of Canada. And it was titled, Slow Death by 1,000 Unnecessary Policies. So we're not going to retire trials, we're going to kill trials. And this is the situation in India, and this is absolutely true. In 2012, 2013, there was a large increase in sponsored trials by pharmaceuticals in the pharmaceutical companies in the previous decades. Some investigators and CROs were reported to make huge amounts of money and profits. social activists started to look for people who were harmed in some way. And the word is, a patient says, I didn't know I was in a trial and, something bad happened to me. And then they came out with articles saying trials were exploitative, consent was not obtained or was not informed, processes weren't followed, and the Times of India had a headline, 2,500 people die in trials in the previous years, without saying there was no excess between the active and control groups. And it hit headline news. In India, the government struck a parliamentary committee, and it was like the wrath of God descended on you. It was draconian, and poorly thought out rules were brought in. First, it went to 4 reviews of the protocols. Ethics Committee, the FDA equivalent called the DCGI, and if it was a foreign collaboration, whether it was academic or industry, another committee called the Health Ministry Committee that takes a minimum of 6 months and up to a year to review. And now they've talked about, as I said, each center needs to be accredited as well. That's another 6 months. So today in India, if you want to start a trial, it's somewhere between 12 months and 2 years. Yeah, so that's the first thing. Then they had the compensation clause. So if a patient has an AE, irrespective of whether it's in the active or control group, you have to compensate the patient. And so you wouldn't do trials of cancers or heart attacks or anything serious. And the amount of compensation is decided by local ethics committees. In one of our trials that we're currently running, we pulled out most of our trials, but some of them are long-term trials. And in one of our trials, a patient died, and they said, well, this was in the placebo group. It's unrelated to the treatment, but you better pay the patient something. So it's a perverse incentive for patients to get into trials, because now you get free medical care. Now, the impact is NIH has stopped 40 trials in India. Industry has stopped most new trials, and academic group, including ours, don't start new trials in India anymore. And trials of existing studies, the rate of enrollment has plummeted by 75%. Now, what are the alternatives? The alternatives to large trials and their meta-analysis, well, all these have been looked at: clinical judgment, observational databases, by matching stratification. But we'll talk about 2 of these, propensity matching and instrumental variable analyses, in a minute. But I do believe we need to improve our observational methods, because for some questions, it's impossible to do randomized trials, like harms of toxins. So we need better methods, and we need to make use of natural experiments the best way we can, but we have to keep the caution in mind. So I'm not going to go into all of this, but one of the things to say is, even with modern multivariable analyses, you can have huge biases that you don't pick. And even the direction of effect can be wrong. For instances, with hormone replacement therapy, tons of good observational studies done by no lesser people than people from Harvard showed that HRT had 70-80% reductions in heart attacks. Of course, after the trials, new observational studies came out with exactly the opposite results, but that's a different thing. But the trials suggested substantial harm, 2-fold increase in heart attack and stroke rates. So it was like a 8-fold difference between the trial results and the observational results. So people came up with this propensity analysis matching, which integrates many different predictors for the propensity to get an intervention or to experience an event. Individuals are matched, and there are different ways of doing it. There are smarter statisticians in the room than me. But the consensus now is propensity matching really is no better than standard multivariate analysis. Then we have instrumental variable analyses, and I think there's something here, and especially in using genetics and in Mendelian randomization. In other areas, it could be useful, but the problem is finding a useful instrumental variable. So that is where the challenge is. And I can tell you, here is an example of a superb paper by Stuckel et al. In JAMA, where they took 122,000 people with elderly acute MI, and they looked at the question, does early cardiac catheterization reduce mortality? And obviously the people who were cathed were younger and had less severe MI. Multivariable adjustment gave you a relative risk of 0.1. propensity scoring gave you 0.51, and looking at regional cath rates, that is looking cluster rates, you get 0.84, which is similar to a meta-analysis of related trials, which is about the same. So the thing is, the first two are inflating the results about threefold. So both the HRT and this analysis will tell you be really careful, both about the direction and the magnitude of effects. Now, many of you probably know about Mendelian randomization, and the idea here is you don't influence what genes you have. So if a gene causes a certain risk factor, and if the risk factor causes a disease, and the gene also relates to the disease, likelihood is because that gene has caused lifelong differences in risk factors, that is probably causal. And a very good example is Lp(a). You will see as you have different variants of Lp(a), the levels of Lp(a) go up, but also the odds ratios for coronary artery disease go up. And this is Robert Clark's classic paper in the New England Journal. Now, you at least know it's causal, so it's worth trying to intervene. What you don't know is by lowering Lp(a), you would expect a reduction in coronary disease, but what you don't know is the unintended consequences. And the value, though, of this is the reverse. You can eliminate hypothesis. If you do Mendelian randomization with glucose versus cardiovascular disease, there are 28 genes that have been identified for diabetes. Not one of those genes related to cardiovascular disease. So we could predict trying to lower glucose to reduce cardiovascular disease probably is a waste of time unless your intervention does other things. And so far, not a single trial of glucose lowering, and there's probably been about 15, 20, close to 100,000 people in the literature, has shown a reduction in cardiovascular disease. So we're wasting our time there. HDL raising, again, lots of genes that are predicted. HDL is predicted by genes, but those genes don't relate to MI. CRP, uric acid, homocysteine. So this could be used as a good screening test to decide which hypotheses you don't pursue. Now, I just want to say the large simple trial will not have rejuvenation unless we have a new name. And this is the so-called Pressy wheel and the pragmatic trial, and you need a new name, and it's called a pragmatogram. So in future, you will have not only PCOT, you have to deal with pragmatograms in your trial. But the basic principle here is right. We should do more trials that are towards the outside of this, simplifying and making things flexible, and fewer trials towards the middle. And in reality, most trials are somewhere in between. But increasingly, we should get out to the outer circles. I'll skip this, and I'll just say I want to say two things, actually. Let me see if I can go backwards. I can't. Okay. First is, we really need to be serious about assessing therapies, and we really need large trials that distinguish between no effect and moderate effects, not between no effects and large effects. And for that, you need really large studies. We need to pay more attention on external applicability, and therefore we need to broaden our approach in doing trials. About 90% of what we do in trials today, even by the experts, is useless and is wasteful, and they're crushing trials now. And when trials are not practical, alternate design should be explored, but boy, you just have to be very careful in how you interpret. I'll go back to saying we need more pragmatic, large and simple trials, and at low cost. We can't afford the $100 million studies. We really need to do it at 10% of those costs, or even 1% of those costs. And the other thing is the implications of complexities. At one time was only money, but today it is, it's become a medical emergency. Complexity and over-regulation is killing trials in some countries, especially some countries like India with a large disease burden. The fundamental loss is not that drug companies can't make more money or you and I can't write more papers. It's that the health of people in these countries are going to suffer. So in India, sure, companies will go to some other country, but you're not going to develop interventions for local problems. So reversing these perverse, and I've deliberately chosen this word, perverse complexities and waste in clinical trials is not a necessity, it's a public health emergency right now. Thank you.